My name is Jung-Woo Lee, and I have the pleasure of talking to you about how to choose the initial anti-seizure medication. Here are my disclosures. There are 3 key sequential questions that need to be asked before starting an anti-seizure medication. Was it a seizure or something that mimicked a seizure? Once you decide it was a seizure, was it provoked? Once it has been determined that it was unprovoked, does the patient have a high chance for recurrence? In other words, does the patient have epilepsy? The 4th question, whether the patient has a focal or generalized epilepsy, is important but does not need to be answered before starting a medication. This is the most recent American Academy of Neurology guideline that addresses this issue as to whether to treat an unprovoked first seizure. There's no straightforward answer to this question. Up to 10% of the population will have a seizure during their lifetime. The recurrence risk after one unprovoked seizure is estimated to be between 21 and 45%. There are certain factors that increase the risk for a second seizure that are listed here. After a second unprovoked seizure, an anti-seizure medication should be started. Treating immediately does reduce the risk of seizures in the next 2 years. However, it will not result in greater chance of long-term seizure freedom, and patients are more likely to end up on medications they may potentially not need. In other words, the medications treat the symptoms, but not the cause of epilepsy. In general, you treat patients who meet the definition of epilepsy, that is, they have 2 unprovoked seizures, they have an unprovoked seizure plus high risk for another seizure, or they have a recognized epilepsy syndrome. Medication is often not started for one unprovoked seizure. So, once you have made the decision to treat, now you have to choose an anti-seizure medication. There are more than 24 FDA-approved anti-seizure medications. They can be divided into the older first generation or the more modern second and third generation medications, those that were introduced after 1993. Some of these are either no longer available or side effects are such that they really are not appropriate for consideration as first-line treatment. Choosing the initial anti-seizure drug is a personalized decision that involves multiple factors. First and foremost is efficacy. Will it be effective in preventing seizures? There is not as much robust data as one would hope for. The safety and tolerability is a key consideration. Are side effects manageable? Are there long-term side effects? Patients with epilepsy often have comorbid conditions. Will the medication treat one of the comorbidities? Will it make it worse? Does the patient have concurrent medical conditions that may affect the drug usage? Does the patient take other drugs that may interact? Cost is quickly becoming more relevant in treating epilepsy. Is the medication affordable given the patient's insurance status? Ease of use is important, both for the patient and the physician. How many times a day does the patient need to take it? Can it be started quickly, or does it need a difficult titration? Do labs, EKG, or echocardiograms have to be performed regularly? There is an important set of clinical trial, the SANAD, or Standard and New Anti-Epileptic Drug Studies. The initial studies were published in 2007, the second in 2021. They are all open-label trials of newly diagnosed epilepsy. The first focal epilepsy trial tested carbamazepine, gabapentin, lamotrigine, oxcarbazepine, and topiramate. The generalized epilepsy trial tested valproate, lamotrigine, and topiramate. The primary outcome was 12 months seizure remission. The secondary outcome was time to failure. In summary, the first SANAD study established lamotrigine as the drug of choice for focal epilepsy, for better tolerability and approximately similar efficacy as carbamazepine. Valproate was found to be more efficacious than other drugs for generalized epilepsy. In the SANAD 2 trial for focal epilepsy, levetiracetam and zonisamide were compared to lamotrigine. For the generalized epilepsy, levetiracetam was compared to valproate. Here are the results for focal epilepsy. Levetiracetam was inferior to lamotrigine in 12-month remission, and both levetiracetam and zonisamide were inferior for time to failure. The treatment failures were essentially due to side effects, not seizure control. For generalized epilepsy, levetiracetam was inferior to valproate on both outcome measures, and this was due to poorer seizure control. There is also an Academy of Neurology practice guideline to help with the process in selection of a new anti-seizure medication, initially published in 2004 and updated in 2018. This is from the 2004 guideline, the recommendations for various anti-seizure medications. You may notice that some of the results are not in agreement with the SANAD studies. Levetiracetam was not at the time thought to have sufficient evidence for monotherapy, but it is probably the most widely used first-line medication for new onset seizures. Here's the data from the most recent guideline. I'll highlight a few results. Lamotrigine is better tolerated than carbamazepine in the elderly. Levetiracetam and zonisamide are as effective as carbamazepine, and there is still insufficient evidence for some of the newer anti-seizure medications. These are some practical considerations, and some are my opinions. Overall, given our previous results, I prefer to start a modern anti-seizure medication. You can and sometimes should treat after one unprovoked seizure, either if you think it will recur or if it has caused a significant injury. It is sometimes hard to determine whether a seizure was provoked or unprovoked. If the seizure is provoked, there should be a clear provoking mechanism. Sleep deprivation should never by itself provoke a seizure, for example. Patients with generalized epilepsies have more specific medication concerns. Some of the medications are ineffective or even counterindicated. We saw from the SANAD studies that valproate is definitely the most effective medication. I consider it first line for male patients. These are the modern medications that are known to be effective and can be used when one isn't sure whether the epilepsy is focal or generalized. These may be also first line for female patients, especially in the childbearing age. One should be familiar with the common, idiosyncratic, and long-term side effects of the medication you're prescribing. Discussing them with the patient beforehand will cut down on anxiety and phone calls. With newer medication, you generally do not have to check drug levels. With the older ones, you likely do. For patients with concurrent medical conditions and comorbidities, certain medications may be more appropriate. Lamotrigine is best tolerated in the elderly as compared to other medications. Lamotrigine and levetiracetam may have the most safety data for pregnant patients. Levetiracetam valproate, and gabapentin may be most appropriate for patients prone to allergic reactions. Mood disorder is very common in epilepsy, and these medications may help improve symptoms. Topiramate is probably the most effective medication for migraine prophylaxis, but both topiramate and valproate should be avoided in the women in the childbearing age who are about to become pregnant. Topiramate may cause substantial weight loss. Valproic acid should be avoided in patients who are overweight. Patients with renal and hepatic failure may need medications to be more carefully selected and dosed properly. Some medications allow you to dose without much titration. Nonetheless, your patients will likely tolerate a medication better if it is started at a low dose and titrated slowly. Once daily medications are extremely helpful in patients with compliance problems. This is a study that I find extremely helpful. It gathered trial results and expert opinion and put it on the website. You can put in your own patient's individual characteristics here, and it will give the optimal medications options. Cost of medication has become increasingly important consideration in starting a new medication. My recommendation is to start with one that has generic formulation, and there are now many excellent, effective, well-tolerated medication for both focal and generalized epilepsy. Ask the patient how much they pay. They may not tell you otherwise. These are the ones that currently have FDA monotherapy indications. Levetiracetam and lamotrigine are likely the most commonly used medications in the United States. Is lack of FDA monotherapy indication a concern? Anti-seizure medications are typically developed and tested as adjunctive therapy for patients who are already on anti-seizure meds, and monotherapy placebo-controlled trials cannot be done safely. So, monotherapy data is much sparser. I will make the case that FDA monotherapy indication does not need to be followed and can sometimes be misleading. There has never been a drug that has been shown to be effective as adjunctive therapy that is not also effective as monotherapy. A drug in monotherapy is likely to be safer and better tolerated than in adjunctive therapy. Dosing indication for monotherapy is skewed to be higher due to the FDA requirement for a drug to show superiority than non-inferiority. For example, monotherapy indicated dose for topiramate is 400 milligrams a day. Most patients need less. For oxcarbazepine, it is up to 2,400 milligrams a day. Most patients need less of this drug as well. Insurance coverage failures may occur for expensive drugs for not having tried cheaper drugs first, but not because of the lack of monotherapy data. However, the landscape is changing rapidly. Liability has not been reported for off-label use, even though we may worry about it. In summary, again, these are some of the key aspects to consider in deciding how to choose among the many anti-seizure medications: its efficacy, its safety and tolerability, comorbid conditions, especially nowadays, the costs and the ease of use. both by the patient and the physician. Thank you for your attention.